Welcome, everyone, and thank you for joining me this evening. My name is Justine Sherman. I've been a speech pathologist for almost 30 years now, and I'm the proud owner of Justine Sherman and Associates, which is a private clinic with 3 clinics across Southern California and remote therapists across the United States. Tonight's course is called Caregiver Coaching Across the Lifespan, a family-centered approach to therapy. No matter the age of the clients we're working with, whether it's toddlers, a school-age student, a teenager, an adult, progress depends on what happens outside of the therapy session. So today we're going to be talking about how to involve caregivers, communication partners, teachers, spouses, and support staff so therapy leads to real-life functional outcomes, not just progress in the therapy room. This course applies to SLPs working in early intervention, schools, clinics, private practice, teletherapy, and adult settings because caregiver involvement looks different at each stage of life, but the core principles remain the same. Let's begin by talking about what you'll gain from tonight's course. By the end of this course, you'll be able to do 6 specific things. First, you'll be able to describe the principles of family-centered therapy and what that actually looks like in practice. Second, you'll be able to explain why caregiver involvement is critical to functional outcomes across the lifespan, not just early intervention. Third, you'll be able to identify concrete strategies to engage caregivers and communication partners during therapy sessions. Fourth, you'll be able to demonstrate specific coaching techniques that support carryover and generalization. Fifth, you'll be able to apply a caregiver coaching framework across settings, including clinic, school, home, and teletherapy. And finally, you'll be able to evaluate whether your coaching approach is working and adjust it when carryover is not happening. Everything we'll cover today will connect directly back to these objectives. So let's start with why caregiver involvement matters. Research consistently shows that when caregivers are involved in therapy, clients make progress, skills generalize more easily, functional outcomes improve, participation improves, and overall quality of life improves. And this is true for early intervention, school-age students, and adults. Caregiver involvement is one of the most important predictors of success in therapy. And this is because communication doesn't just happen in the therapy room. Communication happens all day long in real environments with real people. So if we want functional outcomes, we have to involve the people who are with the clients the most. That understanding leads us to an important reality check about how much time we actually spend with our clients. When we think about the impact we can truly have as therapists, we have to start by being honest about the time. There are 168 hours in every week, which I often represent in therapy with a jar full of jelly beans or pebbles. So I show that to the family and I say each jelly bean or pebble represents one of the hours in the week. And then I take one out and I say, this is what I get to spend, and the rest in the jar are the time you get to spend. So in most cases, we just see a client for one of those hours. That means for the other 167 hours, we're not there with them. The client's at home or at school or in the grocery store or playing or eating meals, getting dressed. They're living their real life. And during all of that time, the people who are there are the caregivers. So this is the reality of therapy time. That 1 hour a week is important. It's where we assess and model and plan, but it's not enough on its own to create meaningful, lasting change. Speech and language skills don't grow because a client said something correctly in the therapy room once a week. They grow through repetition and consistency and use across real routines. Now imagine the difference between a client practicing strategies for 1 hour a week versus getting dozens or even hundreds of natural practice opportunities throughout those 167 hours. This is where caregiver coaching becomes essential. When caregivers and support systems understand what strategies to use, why they matter, and how to naturally incorporate them into everyday interactions and routines, well, we multiply the impact of that single therapy hour. We move from being the only person working on speech and language once a week to a coach who empowers the family to support communication all week long. Caregiver coaching doesn't replace therapy, but it extends it. It turns therapy from a single weekly event into something that lives in the client's daily life. And when families are confident and consistent in using these strategies, progress happens faster, skills generalize more naturally, and outcomes are stronger. And that's why caregiver coaching isn't an extra. It's how we make the most of the reality of therapy time. To understand how this looks in practice, we need to consider the caregiver's role across different stages of life. Caregiver coaching is often associated with early intervention, but it is not limited to early childhood. In reality, caregiver and communication partner coaching is relevant across the lifespan. It simply evolves based on the client's age and needs and goals. So, in early intervention, caregivers are the primary interventionists. They are with the child for nearly all of their waking hours. So, our role is to coach parents and caregivers to recognize communication opportunities and embed strategies into everyday routines. Therapy doesn't just happen during the sessions, it should happen during meals and play, dressing, daily interactions. And as children move into the school age years, the model shifts slightly. So parents and teachers become key partners in supporting carryover. We collaborate with families and school teams to reinforce strategies across settings, helping those skills generalize beyond the therapy room and into the classroom or peer interactions and academic tasks. In adolescence, caregiver coaching looks different again. Our focus moves from being the primary communicator to supporting independence and self advocacy and functional communication. Caregivers play a crucial role by creating opportunities for teens to problem solve and communicate their needs and take ownership of their strategies while still providing appropriate support and structure. And in adult therapy, caregiver coaching remains just as important. We may be training spouses or family members or health aides or other communication partners to use supportive communication or feeding strategies. And whether the goal is recovery, compensation, or participation, progress depends heavily on how communication partners interact with the client in daily life. So, across all of these stages, the common thread is this: therapists do not work alone. While the roles of the caregivers and support partners change over time, the coaching model remains consistent. We assess, model, educate, and empower the people who spend the most time with our clients so that communication support extends far beyond the therapy hour. Caregiver coaching isn't a phase or a specialty, it's a foundational approach to effective speech and language therapy across the lifespan. So this brings us to the foundation of all this work, which is family-centered therapy. According to ASHA, family-centered practice is a collaborative approach to speech therapy that emphasizes a strong partnership among the individuals receiving services, their families, and their providers. Each member of the team plays an essential role and is valued for their unique knowledge, skills, and experience. Family-centered therapy is more than just a philosophy. It fundamentally changes how we approach our work. First, family-centered therapy means that families are active participants in the therapy process, not passive observers. They're not just watching sessions happen or receiving brief updates at the end of therapy. They're engaged, informed, and involved in understanding the goals, the strategies, and the progress. Second, it means that therapy focuses on real-life needs, not just isolated skills. Rather than targeting communication only within a structured therapy session, we intentionally connect goals to daily routines and meaningful contexts. Maybe that's conversations at home, interactions with others, schoolwork, school demands, community participation. We're asking, how does this skill help the person function better in their actual life? And just as importantly, how can the family support the skill outside of therapy? And finally, family centered therapy shifts our professional role. We move away from being the person who fixes the client during a 1 hour session and toward becoming a coach or someone who teaches and models and empowers others to support communication throughout the week. In this model, progress is no longer dependent solely on what happens in the therapy room. It's built through consistent support, shared responsibility, and meaningful practice across everyday interactions. Family centered therapy recognizes a simple truth. Lasting change doesn't happen because of what we do to a client. It happens because of what we teach others to do with them every day. And the goal of family centered therapy is functional outcomes and caregiver confidence, which naturally leads us to compare two very different therapy models. At the core of caregiver coaching, there's one central goal, which is capacity building. Capacity building means we are intentionally working to increase the caregiver's ability, confidence, and independence in supporting communication, not just during therapy sessions, but every day. If progress only happens when we are physically present, then the client becomes dependent on us, and the caregiver may feel unsure or hesitant or disengaged when therapy isn't happening, and that model limits growth. Instead, our goal is to make ourselves less necessary over time, not because the client needs less support, but because the support system around them has become stronger or more capable. Capacity building looks like this: caregivers understanding what strategies to use, knowing why those strategies matter, and feeling confident in how to apply them within real life situations. Also, trusting their ability to support communication independently. So, when families feel empowered rather than reliant, therapy no longer lives only in the session. It shows up in conversations at home, in problem solving moments, in daily routines, and in meaningful interactions. This approach shifts us away from a model of dependency, where progress pauses between sessions, and toward a model of shared ownership and sustainability. Ultimately, capacity building creates greater consistency, stronger carryover, faster generalization, and more lasting outcomes. Our role as speech pathologists isn't to be the sole expert doing the work for the client. It's to build the capacity of the people who support them every single day. And when a client can use skills successfully with caregivers in daily routines, we have built true capacity. Achieving this requires a strong, intentional relationship with families, which is what we're going to talk about next. One of the most powerful influences on therapy success isn't a specific technique or activity. It's a relationship between the SLP and the family. When families trust us and feel comfortable with us, therapy changes. They're more willing to ask questions, concerns, and be honest about what is or isn't working at home. And that openness gives us better information, which leads to better clinical decision making. A strong family SLP relationship creates psychological safety. Families feel respected and heard and valued as experts on their own lives. And when this happens, they're far more likely to actively participate in sessions rather than passively observe. Trust also drives follow through. Families who feel connected to their therapist are more likely to practice those strategies at home, try new approaches, and stay engaged, even when progress feels slow or challenging. This relationship allows therapy to feel collaborative rather than prescriptive. Instead of families feeling like they're being told what to do, they feel like true partners in the process, working with us towards those shared goals. Importantly, strong relationships support ongoing communication. Families are more likely to tell us when routines change, when strategies feel overwhelming, or when something just isn't a good fit. And that feedback then allows us to adapt therapy so it remains functional and realistic and sustainable. Ultimately, effective therapy is built on more than skill instruction. It's built on connection. And when families trust us, they participate more fully, they practice more consistently, and they engage more honestly. And that directly translates into stronger outcomes for the client. The family SLP relationship isn't an add on to therapy. Again, it's the foundation that makes everything else possible. And there are several key elements that support these relationships. To build a strong, effective family SLP relationship, there are several key considerations we need to be intentional about. First is building trust. So, trust develops when families feel respected and listened to and understood. This includes validating their experiences, following through on doing what we said we were going to do, and creating a space where they feel safe asking questions or expressing concerns. Without trust, families may disengage, no matter how strong our clinical skills are. Second is ensuring families truly understand the techniques. It's not enough for caregivers to watch us model a strategy. They need to understand why it works, when to use it, and how to adjust it in real life situations. Checking for understanding and encouraging families to practice within the session builds confidence and clarity. Third is providing functional, realistic home practice. Families are busy, and if recommendations feel overwhelming or impractical, they're unlikely to be completed. Effective home practice fits naturally into daily routines and feels manageable. When families see that strategies can work within their real lives, follow through is going to improve. Fourth is managing expectations, both ours and the families. This includes being transparent about progress, timelines, and what therapy can and cannot realistically accomplish. When expectations are aligned, families are less likely to feel discouraged and more likely to remain engaged throughout the therapy process. And finally, the relationship must be grounded in teamwork. Families are experts on their lives, routines, and priorities. As SLPs, we bring the clinical expertise, so successful therapy happens when those perspectives come together. Decisions are shared, goals are collaborative, and families feel like true partners, not passive recipients of care. And when we thoughtfully attend to these five considerations trust, understanding, functionality, expectations, and teamwork we create relationships that support consistency, carryover, and long term success. The family SLP relationship isn't accidental. It's something we have to intentionally build. And when these elements are in place, coaching becomes much more effective. So now let's talk about setting expectations. At Justine Sherman and Associates, we created what we call our Circle of Success, and it's a visual tool we share with our families on the first session. So this graphic intentionally is used to show that therapeutic success doesn't come from just one element. It comes from multiple pieces working together consistently. We share this visual with families during their first session to clearly communicate all the factors that need to be in place and be effective for us to make progress. Strong therapy skills are essential, but they're just one part of the process. Those skills are supported by consistent attendance, which allows therapy to build week over week rather than constantly resetting. Consistency helps foster client engagement, where clients feel motivated and safe and willing to participate. And then engagement grows out of rapport, that trusting relationship between the therapist, the client, and the family. And from there, we emphasize the importance of caregiver participation. Families are not meant to sit on the sidelines. They are active, essential members of the therapeutic team. And finally, that participation then leads to home practice, not only formal assignments, but real life practice embedded into daily routines and conversations. So all of these components influence one another, and together they point toward therapeutic success. When one part of this circle is missing, progress can slow down. And when all parts are aligned, therapy becomes far more powerful. So that's why we focus so strongly on setting expectations from day one. We use this visual to help families understand that therapy is a shared responsibility. Our role isn't just to work with a client one time a week for an hour. It's to coach and support caregivers so progress continues during those other 167 hours. And by introducing this model early, families understand their role. They feel empowered rather than surprised when we ask them to join us, and they're better equipped to support communication outside of therapy. This clarity from the very beginning is what keeps the circles of success moving and ultimately leads to meaningful, lasting outcomes. So now let's shift from theory to practical implementation. Before we talk about specific engagement strategies or scripts, it's important to take a step back and look at the overall structure that guides effective caregiver coaching. So, this coaching framework gives structure to caregiver coaching so sessions feel organized and intentional and truly collaborative, not awkward or unstructured. This framework also answers a common clinician question, like, what do I actually do during caregiver coaching? Well, each step gives us a clear role and a purpose within the session. The first step is joint planning. Coaching begins before the interaction starts. Joint planning means taking a few minutes at the beginning of the session to identify the goal for the day, choose a routine or activity that makes sense for the family, and decide which strategy the caregiver will focus on. This might sound like, what's been hardest this week? Or which routine would make the most sense to practice today? Or let's pick one strategy to focus on so it feels manageable. If caregivers don't help plan the session, they're less likely to own that strategy later on. Even 1 to 2 minutes of shared planning increases buy-in and follow-through. The second step is observation. In this step, the therapist models while the caregiver intentionally observes. This is not passive watching, it's guided observation with a clear purpose. So before modeling, set the caregiver up for success by telling them what to watch. Maybe you say, watch how I pause before responding, or notice how I follow their lead instead of directing, or pay attention to how I simplify my language here. During this phase, you have to keep your interaction brief, use real routines or natural play, and demonstrate the strategy clearly and consistently. Caregivers are far more successful when they know exactly what to look for, not just told, watch. Practice is the third part in the coaching framework, and this is the core of coaching. Instead of the therapist being the primary communicator, the caregiver leads the interaction, practices the strategy in real time, and makes mistakes and adjusts with support. So, your role as the therapist during practice is to quietly prompt if needed, to offer brief supportive cues, and let the caregiver problem solve. Coaching may sound like, try that again, but pause a little longer, or what do you think they're ready for here? If the caregiver hasn't practiced the strategy during the session, they're far less likely to use it confidently at home. After practice comes reflection. This is the fourth component. Reflection turns practice into learning. So after the interaction, pause and ask the caregiver to reflect. Like, what did you notice during today's session? Or, well, what felt easier or harder than expected? Or, when did that strategy work best today? That reflection helps the caregivers understand why a strategy works or doesn't work, builds confidence in their clinical judgment, and generalize strategies to new situations. Avoid leading with your own feedback. Let the caregiver speak first, and this strengthens independence and insight. And lastly, we have feedback, and feedback comes last, not first. Effective coaching feedback is specific and it's strengths-based and it's actionable. Examples may be, I noticed how you waited before prompting. That gave Johnny time to respond. Or you adjusted your language when Jill looked confused. That was a great clinical decision. Then you have to connect it back to home use. So where do you think this would fit naturally during your week? Or when do you want to try this again at home? Feedback should increase confidence, not create dependence. The goal is for caregivers to leave thinking, I can do this. So, this framework keeps sessions structured, it clarifies everyone's role, it prevents the therapist from doing all of the work, and it builds caregiver confidence and independence over time. And most importantly, it transforms therapy from something that happens in the room to something that continues all week long. So now that we've looked at the structure behind caregiver coaching, let's break down what this actually looks like in real time during a therapy session. Here's a very practical way to structure a session using this framework. So you're going to start with that check-in and joint planning, and then have the caregiver observe you interacting with the client. Maybe that's about 5 minutes for each of those. And then spend most of the session on practice and coaching. Then you take a few minutes to reflect and then end with the plan for home. So overall here we have a 50-minute session. And again, this can be altered if it's a 30-minute session, if it's longer. This structure works in almost any setting. You just have to adjust for your setting. When we use a coaching framework intentionally, caregiver engagement doesn't happen by accident. It's built into the session. Active engagement is simply what the coaching framework looks like in action. It's how joint planning and the observation, the practice, the reflection, and feedback show up moment to moment during therapy. So active caregiver engagement means that the caregiver is not just sitting in the room watching you. They're observing with a purpose. They're practicing strategies and asking and answering questions. They're reflecting on what worked and helping plan what will happen at home. If the caregiver is passive, we're not fully using the session effectively. So now let's talk about specific ways to make this happen. Sometimes the biggest barrier is just knowing what to say. So here are some simple phrases you can use in your session to start building that engagement and pulling the parent into the session with you. Mom, watch how I do this. Now you try. What did you notice there? Let's try this again together. When could you use this at home? These prompts naturally shift the session from therapist-led to caregiver-involved. You model the skill, invite the caregiver to practice, reflect together, and then plan for home. This naturally supports carryover. Another way to engage caregivers is to use we language. The language we use with families has a powerful impact on how therapy is experienced and whether caregiver coaching is successful. Using we language shifts therapy from something the therapist does to the client or the family into something we do together. This is not a communication style, it is a coaching strategy. When we use we language, we reinforce shared responsibility. Caregivers feel less blamed, less judged, and more supported, and therapy becomes collaborative rather than prescriptive. In contrast, when we rely on you language, families may feel pressure or guilt or fear of doing it wrong, even when that's not our intention. So, where we language matters most. We language should be used consistently across multiple points in therapy. You can use it when setting goals, for example. Instead of saying, you need to work on this at home, we could say, we'll work on this during daily routines this week. You could use it when modeling strategies. Rather than, this is what you should do, we could say, let's try this together and see how it feels. You can use it when giving feedback. For example, I noticed how well we supported communication there instead of isolating the caregiver's actions. And use it when discussing challenges. If carryover isn't happening, avoid, why didn't you try this at home? And instead say, let's look at why this was hard and how we can adjust it. We language reinforces the idea that therapy is a shared process. It supports capacity building because caregivers feel safe trying those strategies, making mistakes, and problem solving with us. And this directly increases follow through. Families are more likely to practice strategies when they feel supported rather than evaluated. Using we language also strengthens that family SLP relationship. It builds trust and keeps communication open, which is essential for long-term success. Here are a few simple but powerful language swaps you can use immediately. You should try this at home becomes, let's think about where this fits into your week. Did you practice becomes, when did this feel easiest to try? You're not doing it right becomes, let's adjust this so it feels more doable. This didn't work becomes, now we know something about what your routine needs. Using we language reminds families that they are not alone in this process. It communicates partnership, flexibility, and shared ownership of progress. These small shifts in our language can lead to big shifts in caregiver confidence, in their participation and carryover, and that's exactly what effective caregiver coaching is designed to do. So let's shift now to explicit coaching for carryover. Carryover is the goal of therapy. It happens when strategies are used daily in real routines and when caregivers feel confident enough to use them independently. If a skill only happens in our therapy room, it's not truly learned. Carryover is not luck, it is intentional. It's intentionally coached. Let's look at the core coaching techniques that support this process. When we talk about caregiver coaching, the goal is carryover, and it's what happens outside the therapy room. To support that, there are 4 key coaching techniques that work across ages and settings. As we previously mentioned, we have to model the strategy and ensure the caregiver actually sees what that strategy looks like in real time, so it's concrete and meaningful. Second, that caregiver practices the strategy with our support. This is where the learning really starts to stick. We step back just enough for them to try it, while we still stay present to guide them and prompt them or adjust as needed. The goal is confidence, not perfection. Third, as we discussed, we provide that specific feedback to help caregivers understand what to repeat and why it matters. And then finally, we collaborate on a real life plan. We talk through when and where and how this strategy will be used outside of therapy, maybe during meals or phone calls, homework time, daily conversations. This step is critical because carryover doesn't happen by accident. It happens when we help the caregivers intentionally build strategies into their everyday lives. Once caregivers understand the strategy, our next responsibility is to help ensure it generalizes beyond the therapy room. Generalization doesn't happen automatically. It has to be intentionally supported. So there are 5 evidence-based ways we can coach caregivers to make that happen. First, we use multiple settings. If a skill only works at the therapy table, it's not truly functional yet. So we intentionally practice the strategy in different environments, maybe seated or standing or walking, at home, in the community, or during daily routines. We can coach caregivers to think about where this skill actually needs to work in real life and then help them practice it there. Second, we use different people. So communication is social by nature, and skills need to work with more than just the client and the SLP. We encourage practice with parents or partners, siblings, teachers, caregivers, or friends. During sessions, we can rotate communication partners or coach caregivers on how to prompt others to respond consistently. This helps the client learn that the strategy isn't tied to one person. Third, we use real materials. Generalization is much stronger when we move away from therapy-specific tools and use the items the clients encounter every day. That might mean real books or real phones, real food, real schedules, real conversations. And coaching caregivers to practice with familiar materials makes the strategy more relevant and easier to remember. Fourth, we can vary routines. If we always practice the skill in the same sequence or activity, the skill then becomes rigid. So, by changing the order of activities, the timing, or the context, we help the learner become more flexible. So, we can coach caregivers to intentionally mix things up while still targeting the same underlying skills. And finally, we focus on practicing functional skills. The more meaningful the task is, the stronger the carryover. So we prioritize skills that directly support participation, things like requesting, help expressing needs, managing breakdowns, or staying on topic in conversation. When caregivers see how a strategy improves everyday communication, they're more likely to use it consistently. Now, let's look at how this framework applies across settings. In outpatient therapy, the caregiver should be in the session and actively involved. In school based therapy, we may be coaching teachers or providing strategies for classroom use. In home based therapy, we focus on routines and real life activities. And in teletherapy, the caregiver often becomes the hands on partner, which actually creates great opportunities for coaching. Early intervention is where caregiver coaching is not optional, it's essential. In early intervention, the caregiver is the primary interventionist. They are with the child during nearly all of their waking hours, which means their interactions have far more impact than anything we can accomplish in a 1 hour session. Because of that, early intervention therapy should rarely look like the therapist working directly with the child while the caregiver observes. Instead, our primary role in early intervention is to coach the caregiver, to model those strategies briefly, then support the caregiver as they practice those strategies during real interactions with their child. Coaching in early intervention happens within natural contexts, especially play and daily routines. Play is the primary context for learning at this stage because it's motivating and meaningful and developmentally appropriate. So during sessions, we intentionally focus on parent child interaction. We observe how the caregiver naturally communicates with their child, identify their strengths, and build from there. Rather than directing the child, we should coach the caregiver to follow the child's lead, respond to their communication attempts, and model simple functional language. Modeling is important, but it should be brief and intentional. Before modeling, the therapist should tell the caregiver exactly what to watch for. Like an example is watch how I pause before responding, or notice how I follow their lead instead of asking questions. After the modeling, the caregiver should take over the interaction while the therapist steps back and coaches. This is where the learning really happens, when caregivers practice strategies during the session with our support. If caregivers don't practice during the session, they're far less likely to feel confident using those strategies at home. So, early intervention coaching is about building caregiver confidence, not caregiver compliance. And when caregivers experience success during the session, they leave knowing, like, I can do this. And that confidence leads to consistency. So, in early intervention, success is not measured by how well the child performed during our session. Success is measured by whether the caregiver understands the strategy, feels confident using it, and can apply it during daily routines. And when we coach caregivers effectively in early intervention, we create long term, sustainable progress that continues far beyond our sessions. Caregiver coaching in the school age years often looks different than early intervention, but it's just as important. In school age therapy, our primary goal is generalization. Skills need to show up not only in our therapy room, but also in the classroom, at home, and in social settings. And because of this, caregiver coaching often expands beyond parents to include teachers or aides or other adults who regularly support the child. At this stage, caregivers are no longer the primary interventionist in the same way they were with early intervention, but they are critical to carryover. Parents support communication during daily routines such as homework or morning and evening transitions, meals, and conversations. Teachers and school staff support carryover in academic tasks, classroom discussions, peer interactions, recess, lunch, and task completion. If strategies are only used during therapy sessions, skills are unlikely to generalize. So, in practice, school age coaching focuses on helping caregivers understand how therapy goals connect to real world demands. So, rather than asking families to recreate therapy activities at home, we coach them to embed these strategies into routines they already have. For example, homework time may be an opportunity to support organization, following directions, expressive language, or comprehension, depending on that child's goals. Conversations during meals or car rides may support vocabulary development, sentence formulation, narrative skills, or pragmatic language. One of the most important mindset shifts in school coaching is letting go of perfection. Caregivers do not need to use strategies exactly the way we do it for therapy to be effective. Our role is to coach consistency, not correctness. Now, don't get me wrong. If we're doing articulation therapy, we need to be able to teach the caregiver exactly how we need the tongue or the articulators to move to practice. So that needs to be correct. But we really want to focus on them utilizing these strategies in everyday situations to help them generalize. So when caregivers understand the purpose of a strategy and feel confident adapting it to their routines, then carryover is going to improve. And whenever possible, school age coaching should include communication across settings. So, this might include sharing strategies with the teachers or the aides, collaborating with educational teams, or helping the caregivers understand how therapy goals align with classroom expectations. Even minimal communication, such as identifying one shared strategy, can significantly improve generalizations. And success in school age therapy, again, is not measured by how well a child performs during a structured activity. Success is measured by whether skills are showing up during real academic tasks or daily routines and social interactions. And when caregivers and teachers understand their role, therapy becomes more efficient, more functional, and more sustainable. In adult therapy, caregiver coaching is often referred to as communication partner training. The key idea behind communication partner training is that therapy is not only about changing the client's skills, it's also about changing how communication partners interact with the client in daily life. So even when an adult client understands and can use strategies in therapy, real life communication success often depends on how that communication partner responds to them. Communication partner training focuses on the interaction rather than just the individual. So we're teaching spouses, family members, caregivers, or support staff how to modify their communication behaviors so interactions are more successful. This might include slowing down or giving the client more time to respond, or simplifying their language, or using visual or written supports. And these changes often have a greater impact on communication success than the client working harder to produce perfect speech or language. Many communication breakdowns in adult therapy are not caused by the client's impairment alone. They occur because the environment moves too quickly, or questions are too complex, or the wait time is too short, or communication demands are too high. So, when communication partners understand how to reduce these barriers, conversations become more successful and less frustrating for everyone involved. And one of the most important outcomes of communication partner training is reducing pressure. When partners learn to slow down or reduce complexity and accept all communication attempts, then clients are more willing to participate. And this then supports confidence and independence and dignity, particularly for individuals with aphasia or cognitive communication challenges, motor speech disorders, or maybe a progressive neurological condition. When providing communication partner training, our role is to coach, not to correct. So we model strategies briefly, We explain the why and the how, and then support the partners as they practice during real conversations. And feedback should be specific and strengths based, focusing on what supported communication successfully. This builds confidence and increases the likelihood that the strategies will be used outside of therapy. So, in adult therapy, success is not defined by perfect communication. Success should be defined by participation, by being able to express needs, engage in conversation, and connect with others. Communication partner training is what allows that outcome to happen consistently in real life. Now, let's talk about teletherapy and home based coaching. Teletherapy and home based services naturally lend themselves to caregiver coaching because therapy is happening in the client's real environment. So instead of trying to generalize skills from a clinical setting, we can coach caregivers and clients directly within the context where communication actually needs to happen. So, one major shift in teletherapy is that the caregiver becomes the active therapy partner rather than just an observer. And because we're not physically present, the caregivers often take on roles such as setting up the activities or supporting routines or interacting directly with the client while we coach. And this creates built in opportunities for modeling and practicing and reflecting and feedback throughout the session. Teletherapy also allows us to embed strategies into daily life in a very practical way. We can work on communication during meals or homework or household tasks or everyday conversations. So instead of creating artificial therapy activities, we can coach caregivers to use strategies in real moments as they happen. Technology plays an important role by allowing us to observe interactions and provide immediate feedback. And we can watch how a caregiver prompts or waits or responds or repairs breakdowns and then coach those small adjustments in real time. This makes our feedback specific and meaningful and immediately applicable. And because of this structure, the carryover is no longer something we hope will happen between sessions. It's something we're intentionally building into every session. The therapy itself becomes practice for real life communication. And when we think about key priorities for teletherapy and home based therapy coaching, the first is using household routines and materials, items that are already part of their daily life. And that makes them easier to access, easier to remember, easier to use consistently after the session ends. And another priority is live caregiver participation. So, even brief moments of guided practice during sessions help caregivers feel more confident and capable. The goal is not for the caregivers to do everything perfectly, but for them to understand how to use the strategy in a way that works for their family or household. And that real time feedback and problem solving, those are also essential. Teletherapy allows us to pause, reflect, and adjust strategies together when something isn't working. And this collaborative coaching helps caregivers learn how to troubleshoot on their own outside of the therapy sessions. We also make sure there is a clear plan for between session practice. Rather than assigning vague homework, we collaborate with the caregivers on when and how the strategy will be used during the week. And that's keeping expectations realistic and manageable. Ultimately, the focus of teletherapy and home based coaching is independence and sustainability. So, by coaching within real routines and real environments, we help caregivers and clients build skills that last, not just skills that work during therapy. So, one of the most common questions clinicians ask is, how do I know if my caregiver coaching is actually working? Well, this is an important question because progress in caregiver coaching doesn't always show up first in standardized data or therapy room performance. Instead, progress shows up in behavior, specifically caregiver behavior and real life communication. So, one of the clearest signs that coaching is working is when caregivers begin using the strategies without being prompted. And this might look like a caregiver automatically pausing to give wait time, or modeling language naturally, or adjusting their communication without needing reminders. If caregivers are still asking, "Am I doing this right?" every session, then the coaching may need to be simplified or adapted or reinforced. Confidence is another key indicator of effective coaching. Confident caregivers are more willing to try strategies, adapt them to different situations, and problem solve when something doesn't work. So you may hear a caregiver say things like, "We tried this at home," or "I noticed something interesting this week," rather than focusing on what they didn't do. And another critical indicator is whether the skills appear outside of structured therapy activities. So caregivers may report improved communication during meals, or conversations, or school tasks, or community outings, or daily routines. Progress that only exists in that therapy room is fragile. Progress that shows up in real life is meaningful. So when coaching is effective, skills begin to generalize across settings and partners and routines. So this might mean a child using strategies at home and school, or an adult using communication strategies with multiple partners. Generalization tells us that the strategy is functional and well supported. And carryover is one of the most practical measures of coaching success. So if caregivers are consistently trying strategies between sessions, even imperfectly, coaching is working. Perfect implementation is not the goal. Consistent effort is the goal. So, one important mind shift is that recognizing that caregiver coaching changes what we measure as progress. When we are no longer only tracking client accuracy during therapy tasks, we are also tracking caregiver behavior, confidence, and consistency. When caregivers grow, clients grow. So, as you think about your caseload, consider this question: which of these signs do you already see, and which one would you like to strengthen? That answer can guide your next coaching decision. So, when coaching doesn't seem to be working, I want to normalize that first. This doesn't mean the caregiver is unmotivated or resistant or not getting it. And it doesn't mean that you, as a therapist, are doing something wrong. It simply means something needs to be adjusted. So, the first thing to adjust is the strategy. If a caregiver is struggling to implement a technique, simplify it. Instead of multiple cues or steps, choose one clear, observable behavior. For example, instead of model language and wait, narrow it to pause for 3 seconds after your child communicates. Simpler strategies are easier to remember and to repeat. Next, look at the routine. If the strategy isn't fitting naturally into the caregiver's day, it's not going to stick. So ask yourself whether you're coaching within a routine they already do, like mealtime, bath time, or getting dressed. And if the caregiver has to create extra time or remember a special activity, the strategy is less likely to be carried over. Then I want you to consider expectations. Sometimes coaching feels ineffective because expectations are maybe too high or too vague. Caregivers don't need to do the strategy perfectly or all day. So set clear, realistic goals, such as try this twice during snack time rather than use this throughout the day. Small successes build confidence and buy in. Another key adjustment is the amount of caregiver involvement. Some caregivers need more observation before participating, while others need more hands on practice right away. So if a caregiver seems overwhelmed, pull back and model more. If they seem disengaged, increase active participation with guided practice and immediate feedback. Finally, examine your teaching style. Some caregivers learn best by watching, others by doing, and others by hearing the why. Try narrating what you're doing, using visuals, or giving brief written take-home cues. If the message isn't landing, it may need to be delivered differently, not repeated louder or longer. The takeaway here is that when coaching isn't working, the solution is flexibility, not pushing harder. So, by adjusting our strategy or routine or expectations or involvement level or teaching style, we can better support caregivers and ultimately get better outcomes from the client. There will be times when caregivers are not able to attend therapy sessions consistently, and this is a reality across settings and ages and service delivery models. A coaching approach doesn't disappear in these situations, but it does need to be adapted intentionally. So, when a caregiver is not present, one effective strategy is sending a short video examples. These can show exactly what the targeted strategy looks like and how it's used during real interactions. Videos also allow caregivers to see tone and timing and prompting in a way that written explanations alone often can't, and they can be rewatched as needed. Another support is providing written steps or summaries. These should be clear, concise, and practical, focusing on what to do, when to do it, and why it matters. Written guidance might include simple bullet points or visual supports or short explanations that caregivers can refer back to between sessions. Scheduling periodic check ins is also an important part of adapting coaching. So, even if caregivers can't attend weekly sessions, brief check ins by phone or email or video allow us to answer questions, adjust strategies, and reinforce consistency. These touch points help maintain collaboration and shared responsibilities for progress. And finally, when caregivers are not available, it's critical to train other communication partners. So, this might include teachers or aides or family members, peers, or support staff. Anyone who interacts regularly with the client can support carryover when they understand the strategy and they respond consistently. Coaching multiple partners helps ensure that communication goals are supported across environments, not just during therapy. So, the key takeaway is that coaching is flexible. Even when caregivers can't be present, we can still prioritize clarity, consistency, and collaboration, all of which support generalization and long term success. So, as we wrap up, I want to leave you with a few key takeaways to ground your clinical decision making around caregiver coaching. First, caregiver involvement leads to better outcomes. Clients make most progress when the people who they spend the most time with are supported and empowered to use the strategies through daily life, not just during therapy sessions. Second, therapy should focus on carryover. What happens outside the therapy room matters more than what happens in the therapy room. Our goal isn't for the client to perform with us, it's for the skills to show up during real routines with real people in real environments. And third, coaching is evidence based. This isn't a trend or a soft skill. It's a clinical approach supported by research across early intervention, pediatric speech and language, motor learning, and adult rehab. Teaching caregivers how to support communication is an intervention, not an add on. And another big takeaway is that family centered therapy works across the lifespan. Whether we're working with toddlers, school age children, adults, or older adults, outcomes improve when we involve families and partners and caregivers in meaningful, respectful ways. And finally, remember that the role of the SLP is evolving. The SLP is both therapist and coach. We still bring our clinical expertise, but we also guide and support and collaborate with caregivers so that progress continues long after the session ends. And when we shift our mindset from I teach the client to I coach the system around the client, we create more sustainable change. And that's what leads to better long term outcomes. So, I want to take a moment for reflection because real practice change doesn't happen from information alone, it happens from intention. So, I'd like you to ask yourself, what is the one thing I'll change tomorrow? Not next month, not when your caseload gets lighter, but what one small shift you can make in your very next session. And that might be modeling more or less and coaching more, leaving space for a caregiver to practice, or explaining the why behind a strategy more clearly. Next, ask yourself, what is one barrier I face? This could be time constraints, caregiver availability, productivity demands, or even your own comfort level with coaching. The goal isn't to eliminate the barrier, it's to acknowledge it honestly so you can work within it rather than feeling stuck by it. And finally, what is the one strategy I'll try? So choose one concrete coaching move, such as embedding strategies into daily routines, using brief in the moment feedback, or setting a simple, realistic carryover goal with a caregiver. One strategy done consistently is more powerful than many strategies done occasionally. Reflection like this helps bridge the gap between knowing and doing. So when we make small, intentional changes in how we involve caregivers, we set ourselves and the families we serve up for more meaningful, lasting outcomes. Thank you so much for attending this evening and joining me and listening and learning about caregiver coaching. If you have any questions, I'm always here for you, and you can reach me at justine@justineshermanslp.com. I look forward to seeing you at a future CEU. Bye-bye.